Good evening, everyone. I'm Sam Thompson. Thank you for joining us. I'm a program manager here at the US UK Fulbright Commission. I'd like to thank you all for joining us for a second public event in our Across the Pond webinar series. This is a new and exciting initiative of transatlantic conversations between Fulbright scholars. Last week, we held a riveting conversation around responsible public engagement in scientific research. And this week promises another fascinating insight into a formidable global challenge in today's world, tracking the COVID-19 pandemic. We're all no doubt familiar with one of the lasting impacts of the current pandemic, the great role of virtual exchange and engagement such as this. We've embraced this approach as an opportunity to connect over our UK and US cohorts of scholars and with you, our audience. Across the Pond brings together two Fulbright scholars, one from the UK cohort and one from our US scholars, to discuss the intersection of their interests. Our vision here at the Commission is a world in which there are no barriers or obstacles to learning, understanding, and collaboration. And this new series brings this to life, and we greatly value your participation with it. This evening's conversation panelists are true disease detectives. While we often hear about the contributions of medical science to the pandemic, there is an army of researchers from other disciplines playing their part in tackling COVID, as well as other infectious diseases. Tracking the spread of illnesses is vital to disease containment. Mathematical modeling is one of the ways that experts can help predict and prevent further outbreaks. Tonight's conversation will provide us with an insight into how mathematics and engineering are playing a role in beating COVID-19. This should be a rare glimpse into the lesser known behind the scenes work, helping us all keep on track in the fight against COVID. Before I introduce our scholars, I just want to get to some housekeeping for tonight. So this event is being recorded. So if you miss any of it, or there's anything you want to go back to, it'll be there online. And if you want to share it with anyone who you think might be interested in it too, it should be on our website within the short future. We also ask you to engage with us tonight as well. So we're going to have the Q&A box active. So if anything happens throughout the conversation that you'd like to go into more depth on, or you'd like to ask a question about, feel free to enter your questions in the Q&A box below. There'll be some notes on our upcoming events at the end of the session too. So without any further ado, I'd like to get to introducing our scholars tonight. So I'm joined by Alex Best, who is a mathematical biologist focusing on models of infectious diseases, particularly the evolution of hosts and their parasites. He's a lecturer in mathematics and statistics at the University of Sheffield, where he's awarded a 2013 Leverhulme Early Career Fellowship. And he's currently a Fulbright Lloyd's visiting scholar in integrative biology at UC Berkeley. Outside of his research, Alex is looking forward to exploring the Bay Area with his wife and 3 children. I'm also joined by Caitlyn Butler, who is an associate professor at UMass Amherst in civil and environmental engineering. She's received a highly competitive NSF Career Award for her early career faculty for her novel approach to wastewater treatment. And in the autumn, she plans to work at the University of Sheffield as a Fulbright scholar studying the role of protozoan communities in drinking water distribution biofilms. And she's looking forward to spending time in and around Sheffield with her husband and 3 children. So thank you both so much for joining me this evening. And one of the ways that I want to start this off, and I suppose both of you, it became clear in those bios that working on COVID-19 isn't either of your primary research objectives. So could I maybe ask how this became relevant to the work that you're doing? What led you to pitching in the way that you have? If I ask you to start us off, Alex, on this.
Yeah, so I interviewed for this Fulbright scholarship in February 2019, when we knew COVID-19 was around. February 2020. And it was inevitable, it was coming, but I even as a disease modeler, I didn't realize it was going to change our lives in the way that it has for the last 18 months. So if my research is on models of infectious disease, but I tend to think more on the lines of kind of ecological communities, so plants, animals, and I have a focus on how they evolve. So obviously diseases put quite strong selection pressures on their hosts to evolve defenses, and then the parasites that cause disease need to evolve to overcome those defenses and infect better. That's where my work focuses. However, in the teaching I do, the sort of more standard and I guess immediately more interesting models of human epidemics are the foundations of what we teach our maths undergraduates when we teach them disease modeling. And so in some ways, it was a natural thing to become interested in. I should say I've not been involved in any of the kind of government advisory work or anything like that, but it's so close to my interest and something that I had some understanding of that I ended up working on a couple of smaller projects. So one thing, thinking about herd immunity with a colleague and trying to explain some of the misconceptions people have around herd immunity. And then also a model I worked with my research group, looking at how we could model an infection in general spreading on a university campus. And yes, those were the sorts of angles I came in from. What about you, Caitlyn?
Yeah, so I'm an environmental engineer by training, and I study wastewater systems. So generally public health is on my radar, but usually from the perspective of protecting communities from their own waste products. But I mean, it was the spring of 2020, our labs were shut down. I had students who needed to finish their work. I needed my lab to get back open, but we were in the middle of a pandemic. And so there's kind of this duality of how I got into this. And so one is just a general curiosity. I saw I knew that within my research community that there were people who were starting to track other diseases using wastewater, so norovirus, poliovirus. And I knew that if I was doing research related to the pandemic, so this is the selfish part, I could reopen my lab. So I approached our university and said, I have the equipment in my lab space and the expertise and skill set to run qPCR protocol, which it is so bizarre to me that I can say qPCR to a general audience, and having now at this stage of the pandemic, everybody knows what a qPCR test is for clinical testing of COVID-19. We adopted the same protocols, but applied them to wastewater. We were basically clinical testing wastewater for COVID-19. And I proposed to my university that we could help with the campus COVID response by tracking those concentrations. So we take it a bit of a step further than clinical testing in that we can actually quantify the amount of COVID in the wastewater signal. And we can say, in this area, the wastewater tells us that there are more infected people or less infected people over a time series. So I've been doing that for my university and the surrounding towns. And then at some point we were doing it for a number of communities in the state of Massachusetts, to just look at the community trends in the wastewater. And it correlates pretty strongly. So it's kind of a backwards approach of tracking disease in a community. So yeah, kind of how I got there and what I've been doing for over the course of the pandemic. And we're going to continue to do it. It's going to continue over the fall as students return to campus kind of in full capacity.
So is that built into your university's plan going forward that you'll continue to do this? And are you going to get more resources to get more accurate data and perhaps work with statisticians to be able to say this much virus in the wastewater means this many people infected and things like that?
So that's this is the hot debate in my research group. It's a hot debate in our community. The wastewater-based epidemiology community is kind of the phrase being used for this. Environmental surveillance is another one. Do we want to quantify or do we want to know positive or negative? And I think this is kind of like where we're at in the pandemic. And I think, over the course of the spring semester, when dorms were open in limited capacity, they wanted to know where the infections were, where the hot spots were. So quantification was really, really important. So knowing how big of a signal we're getting is super important. Now we're transitioning away from that. A lot of people in the US are getting vaccinated. They're making vaccinations required to return and live on campus in the fall. So we're transitioning to a more positive or negative. Is the wastewater catchment, so the area that we're testing, is it positive? Is there COVID there or is there not? And then that would trigger kind of an asymptomatic testing program if it's positive. So that's kind of evolved over time. And yeah, so I don't know. And Alex, how, like, do you see similarly of how the models are used and evolve throughout the phases of the pandemic, or what is asked of the models change?
Yeah, to an extent. I mean, the models that we see on the news programs, they're all based on this very fundamental epidemiological model called the SIR model. So in its very basic sense, all that means is that we divide the population into 3 groups depending on their infection status. So S is susceptible, so healthy, I is infected, and R is recovered. So that's the sort of entry-level model. And there's only 2 processes in that model. You get infected, so you go from S to I, and then you recover, and you go from I to R. Mm-hmm. But we obviously build far more complex models than this. And the epidemiological research groups that have been leading government advice, so particularly places like Warwick, Imperial, Edinburgh, these are people who have a long history of investigating different infections. So I certainly remember quite a while ago now, but things like the foot and mouth epidemic in 2001 in the UK, those groups were very involved in. And they have these far more complex models to hand. And so it seemed to be that the first lockdown in the UK at the end of March, when COVID was already here, or there, since I'm now in the US, but COVID was building, and it was clear something needed to be done, but it wasn't until this study was released by Imperial College, where they had this rather more accurate model that showed some of the likely outcomes and the extreme burden on the NHS if we were to do nothing, that action started to be taken. In terms of how the models have changed, I mean, I'm not enough on the front lines to know for certain. I think that the interesting thing now is looking at the change in distribution of vaccines. So in the US, I think I'm right that very early it just became an open that all adults could be vaccinated, and that it's only the under 12s are the only group who don't have access to vaccines at the moment.
Right.
Whereas in the UK, we took the approach of starting with more vulnerable groups and then coming down in age order. I mean, both approaches are perfectly valid, and I would personally say that in that sense only, the UK approach probably was the safer bet to go through in age order. But it does mean that we're left with primarily younger people not being fully vaccinated at the moment. And then but the mixing patterns between all these different age groups are going to be different. And those mixing patterns, of course, affect how likely you are to give an infection to someone else or pick an infection up from another person. And so particularly when we've got people in their 20s and 30s who now have probably had 1 vaccine, but against the Delta variant, 1 vaccine isn't such a strong protection as we might have hoped. And these are people who are returning to work. After 18 months, they're very much wanting to get back on with social lives, seeing family and so on, completely understandably. But I think now that's going to start mattering, is where these interactions are happening and where the disease can spread. And I think models are looking to take that into account. And I mean, even now, even this far through the pandemic, when we have excellent data from people like Caitlyn and all the Public Health England data, and in the US, the CDC data, you look at the predictions of the models, and there's still a huge variation in what might happen given what we know. And I think that's an interesting thing in itself, is that there are different types of models. And so again, the sort of entry-level models we teach undergraduates, we assume everything is deterministic, which basically means if all of your infection rates and recovery rates are the same, then every time you run your model, you'll get the exact same answer, and you'll get a nice bell-shaped curve that we typically see. Now, what you can do instead is what we'd call a stochastic model, which is to some extent more realistic. And that would say that, well, you will get variation. And just from naturally, depending on who happens to have the infection at what time, the fact that not everybody recovers at the exact same rate, it's going to be a distribution. And once you start building those things in, you do just naturally get a lot of variation in the model output. And that seems to be really hard to get across to the general public, is, you know, when we say models predict this, there's always a variation in there, and this sort of uncertainty of quite what will happen. And the news media tends not to present that variation. It tends to just, you know, give the mean curve and say, this is what's going to happen. Scientists say this many people will be infected, whereas actually it could be anything from half that to double that based on the models. And so I think that, yeah, there's definitely an interesting question of how we explain that uncertainty. I mean, when you're doing your data analysis, how much variation do you see, and how do you take account of that? I'm assuming there's a huge amount of uncertainty when you just get back the numbers. How do you account for that sort of uncertainty?
You know, we're still very much learning, like, what are the variables of uncertainty, and as you know, with any model and with any analysis, there's assumptions built into that analysis, and those assumptions come based on a variety of factors. So one of our big variables is fecal shedding rates. So if somebody is infected and they are shedding virus in their waste, how much virus are they shedding? Is it proportional to their symptoms? Like, so we know, particularly with this virus, you have some super spreaders, and not all of them are very symptomatic. But if they're a super spreader and they're making a lot of virus in their respiratory kind of passages, are they shedding like a proportionally large amount of virus? And we don't know that. We're trying to understand that a little bit. So one of my students did a case study on an isolation residence on campus. So all the students that moved to this space, we knew were positive. We know how long they were there, and we know like when the onset of symptoms are. So then we looked at that wastewater like almost every day over the course of the semester. And so we're hoping to kind of replace the assumptions we have in our data analysis with what we think the fecal shedding rates are based on what we see in the literature, with like actual, like, this is the concentration from an isolation residence, and this is what we're seeing in the wastewater based on these numbers in the residence, which is there's still assumptions based into that, but it's more accurate than saying there was this study done once, they took a sample from a patient in a hospital, and this was the concentration. And we don't know from that study, like, what day of infection they were on. We don't know, you know, the severity of their symptoms. And so that's just one example of different things. And then sewers are all different, right? There's different time between where your sample point is and where the sample was introduced. And so there's a time factor there. And we kind of aggregate this data, and we say this is correlates with the asymptomatic data or the testing data that we have. So we have a strong correlation, but really getting down to, like, if you get this concentration at this point in the wastewater, it means you have 3 people infected in this area, is really, really hard to do. But it's much easier to say, we've been testing the wastewater, this is above the limit of detection of our assay. We can confidently say there is COVID in the wastewater, just like you can confidently say somebody has a positive clinical test. So we're trying to like reframe what we're doing in this, like, positive, the wastewater catchment is positive or negative, versus trying to say there's this many infected people in the catchment. And because we have there was a really, really strong asymptomatic testing program at our campus over the semester. Everybody who lived on campus had to be tested twice a week. And there were some really great programs from the residential life staff to get pretty high compliance with those testing rates. So I think most residents had somewhere in the 80 to 90% compliance with those twice a week testing. We can do some really strong correlation analysis between our data and like the actual rates of infection on campus. So that makes it kind of a robust moving forward. but it's still really hard for me as a scientist to say more than this is above the limit of detection and this is below the limit of detection. Because I also, in working with the community and working with the administrators and working with the residential life staff, I only get an hour of time with these individuals, and I want to make sure what I'm communicating with to them is like beyond clear. Like there's no room for subjectivity. There's always room for subjectivity, but like I try to make it as objective as possible so that these data become actionable and not like, I think in this catchment, this means maybe one person is infected, but in that catchment, this data means 3 people are infected. What do I do with that? And then they're overwhelmed and they don't make the decision. So it's trying to put the information in the hands of the decision makers in a way that's like powerful and useful. And I think actually that's probably been the learning edge, particularly for myself and my students this whole year, is we know how to do the clinical, we know how to do the qPCR protocols, we know how to process wastewater, but we are getting much better communicating our information to I guess non-scientists. We know how to write a paper for a journal. That's our job. That's what we do. But we've been really growing our skill set in communicating to the general public what you can take away from these approaches and what you can't. So that's been interesting. And I know that's always interesting too, when I see, and you mentioned that like when models are presented in the media, you get the mean, and you know there's so much more depth to that model and so many more things that they can say. So what are your thoughts on that, and seeing how models that you work with in your own research being portrayed in kind of the media and other outlets?
Yeah, I mean, to start with, it was just a bit strange that there were these people who I know through science. I'll go to conferences and I'll see them give the keynote speech. The Neil Fergusons and the Julia Golks and the Graham Medleys. These are people who I know as scientists, and suddenly seeing them on BBC News was a bit strange. And then when occasionally you would see a model presented on screen on the news, I kind of turned into a scientist and I'd be looking at it and going, what's that term there doing? Why have they put that on? What on earth does that mean? I mean, I think it's good that we are making sure that modelers and scientists are presenting this themselves, because that is the best way of making sure we get the whole story across. But yeah, I mean, it's not something that I've been doing. So yeah, my COVID-based work has been very much academic, or I guess a bit through Twitter, but that's sort of a different story again of how you attempt to communicate to people. But I've not had that direct interaction with policymakers, whether that's at the university or at the more political level. So yeah, I'm interested in hearing more about how you found that, and what are the challenges, and what can you learn more generally about how we communicate science?
Yeah, that's interesting. So I think something that was kind of organically different about this situation and other situations where I've interacted with communities based on research that I was doing is that because we are all in this shared experience of the pandemic, everybody's processing and digesting information and sharing information. So many of the people I was communicating with, like town officials or university administrators, came in with some initial knowledge about like wastewater-based epidemiology as an approach. They had seen an article in a paper, they had seen something on Twitter, they'd seen something on their news. And so they had these like sound bites of information about what to expect from the data that I had. I think that was one of the most kind of unique parts of these conversations. So an example of that is there was a state legislator that I was in a meeting with, and they had seen an article come from a colleague that I know at another university, and it asserted that there was a predictability in the wastewater data, so that you could see the signal in the wastewater 2 to 7 days in advance of seeing the signal in the community, through positive test cases. And they, of course, the soundbite in the news picked the 7 days of that 2 to 7 day range. And so they're like, so why in your data are we not seeing that week advance notice of the data? And I said, well, you're looking that, but fortunately, like, I know the paper, I knew the details of the paper so I could explain it. But in the paper, they were testing a community wastewater treatment plant. And it was a community without an asymptomatic testing program. They were comparing this to symptomatic testing data. And a lot of these public health departments log the data on the date it's reported to them, not the date of the test or even the date of the onset of symptoms. And there could be a full week between when that person is symptomatic and when that data point gets logged in the public health department. So I said, we are not seeing that in our data because our students are getting tested twice a week, and that data is logged like nearly same day. And so we may see like a day ahead of time, but we're not seeing a 7-day lead time because this is a totally different paradigm of testing here than what you're seeing on the news. And so I think that's just an example of people bringing kind of preconceptions to this data that are important, right? In a community where there isn't an asymptomatic testing program, seeing that a week before you start seeing symptomatic testing in a hospital is powerful and important. But like the absence of that in my data set doesn't mean the data set's wrong. It just means it's a different data set. And that's probably one of the pieces that's been so hard to work through, and also like uncovering what those preconceptions are in the conversation so I can see where they're approaching what I'm sharing and communicating, that see their lens and kind of be able to kind of translate to what they know.
I find that interesting because I think something which, again, the nastier regions of Twitter are quite critical of models. And I think there's something in that name or what people think a model is that somehow it's made up or you're just guessing. And I would have thought that when you're presenting data, that this would be inarguable, that people would accept that what you're saying is true because you've got the data. And it's interesting that even there, I mean, not arguing with you as such, but there are still these subtleties that people are almost not willing to understand fully, or feeding it into their existing worldview rather than adjusting their worldview, perhaps.
Yeah, and I think you say that the darker places on Twitter. I think especially in the pandemic, I think in science, and I think any science related to COVID has exposed a lot of those hot topics on Twitter, and everybody suddenly has become, a scientist, which on the one hand, fantastic. If there's a silver lining to this awful time, like people have engaged with science so much in the last year in a way that they haven't needed to in the past. So silver lining in a terrible time. But at the same time, it's also fueled a lot of misunderstandings and yeah. But I'm sure you've seen that too with model interpretation and knowing the boundaries and assumptions and constraints of a model and what you can take away from that model versus what maybe somebody on Twitter has seen and is taking away from that model.
Yeah, I mean, one of the big misconceptions that we've seen is over herd immunity. So this is something that a colleague and I did write a short paper on, because I mean, it started being mentioned very early on in the pandemic in the UK that this is something that we should aim for, but it was done in a very different way to how I've ever thought about it and taught about it. So herd immunity is basically this idea that once enough people in the population are immune, that the epidemic can no longer spread. So it's very closely linked to this R number that we've heard about, this reproductive ratio. of the infection. So if R is bigger than 1, that means on average, everybody who has the infection is passing it on to more than one person. So naturally the epidemic is spreading. Whereas if R is less than 1, then on average, somebody who's infected is spreading it to less than 1. Obviously you can't actually spread it to 0.5 people, but on average. And herd immunity is precisely when you get R equal to 1. So it's the point when you stop the epidemic from increasing. And that's a really important point that I think has got missed a little. So whenever I've taught herd immunity or thought about it in my research, it's very much in terms of vaccination with the idea that numbers are low. So that's either you have contained an epidemic through lockdowns and what we've been through to try and keep cases low, and now you've got your vaccine ready and you vaccinate everyone as quickly as possible. Or it can be in the case of something like measles, for example, which was a hugely prevalent disease, but over a very sustained period of time, we have got it down to low numbers. And in the mid-90s, we'd almost eradicated measles in the UK before the MMR lies blew up. Mm-hmm. But why that's important, this assumption that we start with low numbers, because that means if we vaccinate, say only 100 people have the infection, but we vaccinate enough people that we force R to be below 1, then those 100 people, they're not going to infect more than one person each, they're going to infect less than one person each. So perhaps they generate 50 new infections, and perhaps those 50 generate 10 new infections, and then it pretty much dies out. So we've only had 160 people infected. But the way herd immunity was being talked about at the start of the pandemic was much more in terms of it emerging naturally by just letting people get infected and we just assume you develop immunity, which firstly at the start, we didn't know for certain that would happen with coronavirus. We still don't know for certain how long immunity lasts. But even so, if you're thinking of immunity in that point, so people were saying, well, it looks like COVID has an R of 3, so I can do the quick maths in my head. That means 67% of the population would be the herd immunity threshold. And people would say that. They'd say once 67% of the population have had it, then we've got herd immunity and it's over. But it's not over. That point is exactly at the peak of the epidemic, because it's the point when it no longer spreads. It's not when the epidemic is over. And we can picture this classic bell-shaped curve that we've already seen in every wave we've had so far. If you're at the peak of the epidemic, you're only a little over half of the total number of infections. So although your herd immunity threshold is 67% of your population, actually in the end, you're looking at 90, 95% of the population who would get the infection if you were thinking of herd immunity just in terms of we let the infection spread and go its natural course. And so this is one of these things where it's great that lots of people are kind of trying to understand some of these terms, and they are looking at models and they are looking at data. But yeah, there are these subtleties that people don't pick up on, and they can be hard to correct because once an idea is out there in social media and even mainstream media, it just carries on going, and it's very hard to correct the record.
It's the correction of the misconceptions that is really hard. I mean, I think I've seen that even a little bit with our within our university, talking with the staff, like the people in charge of our clinical testing center, because we'd love to send some of our samples over there and kind of change our workflow. But it's same protocols, right? But the thresholds for like what is appropriate number of cycles that you run your qPCR. And I know this has been on Twitter, like what's the appropriate cycle count for your qPCR clinical test? And I was like, I never thought I'd see that tweeted by like somebody who is a non-scientist, but there it is right there. And people like Elon Musk debating what is the appropriate cycle count for a clinical like qPCR test. Well, like, but it matters. Like it does change kind of these thresholds of what is positive and what is negative. And there is subjectivity to that, but we do put so many controls in the protocol that to reduce that subjectivity, which of course is not nuances that are carried through Twitter. But even having those conversations with the clinical testing center, it's clear that their thresholds, mindset, frame of reference that they're coming from is like, there's a swab in a nose, or I've even heard a swab in a dog's nose from a student maybe trying to get out of quarantine early. Yeah, there's endogenous controls that'll tell you that it is a non-human sample. We don't have to worry about that. There are things in the protocols that protect for that. But there are frames of reference even within like the same protocol about me approaching it from wastewater and somebody else approaching it from like a swab in a nose, where we still have to kind of like meet in the middle and say, you know, this is the boundaries of what makes sense given the constraints of our two problems. So even among the experts in the situation, it's not always super straightforward of like, this is the right way to do things.
I think the question we've had from our audience is somewhat relevant to this part of the discussion as well, this idea of the public's response to the work that's being done and the communications around it, which is, have you felt pressure to turn around work quickly on COVID-19 because of severity and urgency? And also, have you felt pressure to use fast changing data, and how have you adapted to rapidly changing situations? And then perhaps could you comment on how this compares to the work you're usually involved with? Because I imagine, although perhaps not as far reaching as the COVID-19 pandemic, working on infectious diseases and things on a microbial level can still have a level of urgency to them. So if either of you want to get into that, and if you want to ask me to go over any of those points again, I'm happy to, because I realized that was quite a long question.
Yeah, no. Alex, do you want to go first?
But yeah, I mean, again, because I've not been directly involved in any sort of advisory work, so to an extent, the pressure has been internal and from people I'm working with asking for opinions occasionally. No, I think, Caitlyn, you've probably got the more relevant answers on this.
Yeah, I felt a lot of urgency this year. So, I mean, we went from not running this protocol in our lab and not knowing how to isolate the RNA from the virus in a wastewater sample to measuring it in a wastewater sample in like a month last summer. And it was intense and it rapid. And then there's been this kind of intensity and urgency that's continued through the pandemic to respond to this, to support the campus and to do these things. And I think maybe in contrast, I think to the research I usually do, I think I'm usually the one who feels the urgency. So I'm usually working on how do we make wastewater better in our communities. And I see this urgency of our infrastructure in the US like crumbling around us. And everybody else is like, it's fine. And I'm like, no, we need to fix this right now. So I think there's like then a flip, like where I usually feel the urgency that this needs to be fixed and we need to be working hard. And now the pressure has certainly reversed. It has been. And in terms of the fast changing data, there's been this really kind of amazing thing. I think environmental engineering is generally kind of a strong community of researchers. I know there's lots of science gets a kind of a bad rap for being super competitive. And I would say that in environmental engineering, there's a lot of collegiality and a lot of support already. And one of the things that was born out of that is there was a community of researchers working specifically on these topics with their universities, with different communities, basically have Slack. And for those who don't know what Slack is, it's like social, kind of like social media messaging app where you can message any one of these researchers any time of day and get a response like, my standard is behaving weird. Did anybody else get their standards this week and have strange outcomes? And you can get a response really quick. I've never seen anything like this. It's amazing. It's a super resource. I hope it's perpetuated across other research topic areas. So there's there's been this great kind of convergence of scientists, but that's allowed for some really fast-paced data exchange outside of the traditional publication realms. And even inside the traditional publication realms, I was looking at a paper yesterday that came out, I think it was last June. It has 600 citations, which means there's 600 more papers on this topic since last June. I have not read all of those papers. I don't know who's going to read all of those papers, but that's the level of activity that went in a single year, and that's incredible to me.
Yeah, I've seen quite a few examples where experimentalists from a variety of backgrounds, I guess principally biology and medicine, but also engineering, clearly, where people have turned their labs over for testing. And I think I mean, Sam said at the start about some of the unseen scientific work that goes on. I think it's an incredible amount of work that's been done by people to put their usual research programs on hold to be able to help the COVID response, you know, at universities, but also in communities. And I'm certainly think that's something that should be more widely known is how many people are doing this.
Yeah, I agree. And there's a lot of people that I just know from conferences and stuff who don't do anything related to surveillance of disease in wastewater, who are doing this now just because of expertise in wastewater, expertise in knowing how to isolate DNA and RNA from wastewater, and having the equipment to do so. And they've just switched everything over in order to do this, to support their university or their community or any number of things, or kind of our CDC or the Environmental Protection Agency. There's people have done that as well. So there's been a lot of action in a really kind of positive way.
So I know you said at the start that there was sort of a selfish element to your decision, but I'm interested in how you felt about sort of turning to this direction. So when the pandemic started, you know, there's part of me that thinks, right, this is my ballpark, I should do something. But equally, for a long time, I kind of very much felt that there are much better placed epidemiological modelling groups to be doing this work. And it's kind of not worth me even trying to get involved. And I mean, we both have 3 children at home. Life became very stressful very quickly when schools were closed.
Oh my goodness. Yeah.
And so I kind of ducked out of it for a long time until it was my PhD students who very much pushed me to do something. And I'm really pleased that they did. We got this really nice model done. But how did you kind of feel about changing direction like that?
Yeah, I think it's twofold. I think you mentioned one of the things is that my PhD students pushed me. I said, you know, I can't, like, this was not me telling my students like, we are going to do this, we have to do this. I said, this is an option that's on the table. I think this is a way that we can support our university and our town, but like, I need your buy-in because, as you said, 3 kids, no school, panic. Like, I can't do this by myself. And so it was really getting student buy-in. And then kind of fortuitously, we had a lot of students whose funding situations had changed because of the pandemic. So there was also kind of extra person power that could help respond and address this. So there was ways, it kind of had all these benefits of my students were super engaged, wanted to do it. There was opportunities to support students whose funding situations had kind of changed and buffer their transition into the university. And it was, but I mean, it also kind of, I'm sure somebody can psychoanalyze this, in a time when you're feeling super out of control, like your kids are out of school, like you don't know when the world's going to open back up, this like contributing to a way to support your community and your university in an effort to kind of make things better gives you some semblance of control back in a time where it's really out of control. Everything's really out of control. So there's a lot of dimensions. And I mean, it became clear once we kind of tried it and it worked, that the university was really interested in doing it because it's a non-invasive way to test a community of I'm trying to say this politely, not to insult any young people on this call, but like there is a lot of young people, and a minority of those young people have a different sense of consequences than maybe a lot of other people. And when you're young and healthy and you know this disease has less of an effect on young healthy people, you are willing to take different risks in your life than people who have comorbidities or who are older or who have young children at home. Or so because the risk taking is different among that population, having kind of non-invasive ways to track disease within the population became kind of an attractive thing from the university perspective. So yeah, there's a lot of dimensions to that decisions and how we got there.
No, I can definitely appreciate, yeah, that life has spun out of control. Find something that you can control. So, but not at all on science. I went and volunteered at the local vaccination centre in South Yorkshire near me, and I love doing that. You know, it was 5 hours of bending over, wiping chairs, but it was great to feel like I'm doing something to improve the situation, however small that might be. Yeah, there's definitely a lot to be said for that.
Yeah, I think there is. Yeah, but I mean, I'll leave that there. I had another thought, but then it flew right out of my head.
I suppose it kind of leads on to one of the questions that I've had sitting in the back of my mind, and sort of thought about coming into today even, which was, do you think, and I suppose this is one manifestation of that, this feeling like you're doing something, but do you think your specialization has helped you navigate the pandemic personally, either in terms of the way that you're thinking about it, or just that day to day, this is what I'm doing and this is helping?
Yeah, I think it definitely has helped, and yeah, kind of being able to have a rough idea of what an epidemic will look like from just knowing it, and from years of research and teaching on this. I know what an epidemic curve is going to look like. I've got an idea of when an epidemic could be killed off completely compared to when it's going to end up continuing in the population, what seasonality is going to look like. And so that sort of thing wasn't so surprising to me, I guess, which probably made it a bit less scary. It has been difficult at times being the voice of doom amongst family and friends, you know, because people do know that this is something I know about, and they'll ask me, and you can see that look of hope in their eyes that I'm about to dash with what I think is going to happen. But yeah, you know, knowing, yeah, a bit of knowledge goes a long way, and it does help you cope, I think.
Yeah, I would say the same, that, you know, just knowing, well, one, I was intimately familiar with the actual rates of infection in our community for the entirety of the pandemic. And, you know, sometimes you're having conversations with your kids' school about reopening, and they're like, gloom and doom. And I'm like, there hasn't been a new case in 4 weeks. And they're like, oh, okay, like less gloom and doom. But so, I mean, there's that thing, but I think maybe the more important thing is contextualizing risk and thinking about risk more explicitly. So we do that every day. We've done that every day of our lives. Like when you're a little kid, you're like, can I jump off this swing and will I get hurt, right? So you're contextualizing risk at that moment. But thinking about risk much more explicitly, and then having kind of data to put to those risk-based choices has been kind of interesting as part of the pandemic. And then also reflecting on, you know, how I assess risk for me and my own family, and how, you know, other people assess risk. And I think one of the plays that, and maybe Alex has similar experience, this drifting away from our research and more towards family life, is in conversations about reopening school. And is it safe? Is it not safe? When is it safe? What does the disease rates in a community look like when it's safe? And it's clear that, you know, you can bring the director of the public health department and a pediatrician into it and to have a conversation. But even at the end of the conversation, there are people who are going to be totally reassured by what they have to say, and people who are like, I am locking myself away in my house out here in the hill towns. We have hill towns, and I'm only getting to grocery deliveries for the rest of time, and I will wear a mask inside my own house as well, right? So like, you have these same conversations, and you get people who are like, open all the schools up, and the people who are like, I'm never leaving my house again. So it's the kind of difference there is how you contextualize risk for yourself and your family.
That's really interesting. And then I suppose moving forwards and looking on from this, say 2023, maybe a couple of years later, if we're wanting to be extra safe about this, do you think this has changed the way you'll think about your research going forwards and sort of your area of expertise? And also, do you think the way that it's perhaps brought what you do to a new or different appreciation has changed maybe the trajectory of your research in terms of career or public life as well?
Yeah, I mean, I think anybody in my field for the next 10 years will be starting their research proposals with the COVID-19 pandemic showed the importance of disease modeling. I'm pretty sure that's going to be in there. Yeah, I mean, there's certainly aspects I've seen in models of COVID-19 that have definitely made me think about what I do in my own work, which, yeah, it's got a slightly different direction, but there's a lot of crossover. And there's, so for example, that my models tended to be very much this deterministic approach, because when you're then doing evolution on top of it, keeping your basic dynamics fairly simple is really important. But having done some of these stochastic models myself, and I could show for the exact same parameter values, you could get outcomes from as low as 10% of the population being infected to as high as 80%, just through kind of randomness, just through natural variation that would happen. And so it certainly made me appreciate that more and think, can I do that more in the models that I work on sort of day to day, and appreciate that. Yeah, in terms of a wider audience, it's a bit hard to know. I mean, I guess we're moving into a more of an interest in the evolution of the virus. We're certainly seeing more and more infectious variants emerging, and there's, back in the UK where cases are unfortunately rocketing again, the potential for more variants to emerge, and a lot of talk amongst evolutionary biologists of, if I were to design an experiment to encourage infectious immune escaper variants to arise, a partially vaccinated population with a large number of cases would be a good way to do it. So there's definitely some interesting questions there that I think are still to be looked at over the next couple of years in terms of COVID and evolution. So that's something that I may think about more.
Yeah, I think it'll certainly influence my work moving forward. So a lot of the research that I have done in the past really is trying to think of wastewater as a resource of nutrients or a resource of energy. But I think this whole exercise has reminded me that wastewater is a resource of information. There's a lot of information about communities within their wastewater. And I think there's a lot of opportunity there to explore different dimensions of public health about a community from its wastewater. And I think there's a lot of opportunity there to enhance that.
Yeah, that's really interesting as well. We are rapidly approaching the hour mark. So unless anyone in the audience has any questions, I'm going to fall back to, is there anything we've missed? Is there anything you think that is really relevant to this discussion of sort of tracking or the way that an epidemic evolves that you think we've missed today, or that maybe you want to clarify something that's been in the news recently about it? Anything that you think is a good ending note to wrap up what we've talked about today?
maybe one piece that I've been thinking about a lot lately, but again, I don't have an answer to this question, but I can leave it with the audience to kind of grapple with is, you know, the wastewater-based epidemiology seems to have value. It seems like maybe there are opportunities to practice this strategy in different ways in the future, but there's certainly some ethical issues that go with it, right? So I can keep reducing the catchment size of the wastewater to get to a single household, and then are you doing health-based testing without consent, right? So what is the size of a catchment that provides anonymity to the people within the catchment, but gives you relevant health data that you can respond to things within a community, is something that's really curious to me right now.
I guess the thing that has repeatedly come to me is that the UK government slogan at times has been to follow the science, but that this seems to get interpreted in all sorts of ways, and an appreciation more of what is the science, I think, is a conversation that we could do with having.
Yeah, I think that's and it sort of comes back to what we were talking about last week as well, in terms of how do you communicate science in a ethical and understandable way. In this sense, we're talking about science in terms of, I suppose, trusting data and listening to the advice of experts, but at the same time, science is a method, and you're asking people to, I suppose, be patient when they feel like there's a state of emergency to understand what we're actually dealing with. So trust the science can be a difficult thing to ask people to do. And also what are you, as you say, what are you defining as science in this context as well, is a really interesting point as well. Well, I think we're just about at that hour mark, which means we're gonna have to wrap things up today, which is pains me to do because I was enjoying listening to you so much, and I think this could have gone on for a lot longer with some of the interesting depth we were getting to. But thank you again, both Caitlyn and Alex, for joining me today. It was really great, and I hope there's some other opportunities that people have to hear from you in the future, whether it's something like this again or anything else that you're involved with. We'll try and get the recording online as soon as we can, so that people can follow up and listen to this in their own time. If you're interested and you're sat at home and interested in more of what we do, you can find any information about us on our website, which is fulbright.org.uk. And you can go on the events page and see our upcoming Across the Pond events. So we've got 2 coming up in the next 2 weeks. So next week we have Tackling Trauma, which will be held at 5 p.m. next week on the Tuesday. And then the week after that, we are moving on to talking about community storytelling and cultural institutions. So that'll be the 20th of July. And again, I think that one's at 5 p.m. But I just want to double check. Yeah, 5 p.m. on the 20th for communities, storytelling and cultural institutions. If you want to keep up as well with what we're doing, you can go to our Twitter, where we're US UK Fulbright on Twitter, and you can find us on other social media networks as well. And if you're in the audience and you're interested in science or science communications, we'd like you to share amongst your networks, or even consider applying yourself for our Civic Science Storytelling Award. It's a brand new award. We've just opened it. Please go on our website to get all of the information so I don't drag this out even longer. But it's a really fantastic award, really great opportunity. So we'd really ask you to share that amongst your networks if you are interested in science, interested in communications work. But once again, thank you all for joining me tonight. Thank you especially to Alex and Caitlyn. It's been a fantastic conversation. You've done a fantastic job this evening. Really grateful for your time, and I hope everyone has a fantastic week.